Okay, good evening members and good evening guests and good evening to the people watching at home. This is the Health Scrutiny Committee. It is 7 p.m. on Tuesday the 15th of July. If I could ask everybody in the chamber to please put your phones on silent. We'll start off with item 1 on the agenda. Any apologies for absences, Raj?
Yeah, we received apologies from Councillor Paul Brooke.
On to item number 2, members' declarations of interest. I have a personal interest in this. My wife works for NHFT, who we have in the meeting with us today. Any other declarations of interest?
I'm a member of the Kettering General Board.
Any others? Nope. Thank you. All right.
Yeah.
Yep.
I
Go ahead,
work
Mark.
for the Red Cross, and we are commissioned by Kettering General Hospital Trust.
Thank you, Councillor Pengelly. Any others? No? On to item number 3, minutes of meeting held on the 3rd of March 2025. Now, I don't think there are any members who are returning from that committee, so what we're going to suggest is that we note the minutes of the previous meeting. Would anybody like to propose and second that? Thank you, Councillor McLean, for proposing, and we'll take Councillor Howes for seconding, so we will note those minutes. Okay, on to item number 5. We have the Northamptonshire Integrated Care Board introduction from... item number 4, thank you, Raj. Welcome, introductions and overview of Health Scrutiny Committee from Scrutiny Officer Raj Sahal.
Thank you, Chair. So good evening, everyone, and welcome to our first scrutiny meeting of the new term. So my name's Raj Sohal. I'm the scrutiny officer here who supports the Health Scrutiny Committee. So I'm really pleased to have the opportunity to welcome both new and returning members to the committee and to provide a short overview of what this committee is all about, what it does and why it matters. So following the local elections in May, the council appointed a new membership to this committee at annual council in May. So you're now part of a group of 9 councillors responsible for leading health scrutiny across the area, and it's a really important role, as we know. The council operates an executive model of governance, and that means that scrutiny has a statutory role to play. So under section 9F of the Local Government Act 2000, we must have at least 1 scrutiny committee, but in practice we have 4, along with the Scrutiny Management Board, which helps coordinate the work. So one of these 4 committees is this one, Health Scrutiny, and you'll be shaping its direction for the year ahead. So what exactly is Health Scrutiny? Put simply, we're here to examine and influence the policies and decisions that affect the health and well-being of our residents. This includes everything from local NHS services to social care, public health, and inequalities in access and outcomes. While we don't make the decisions ourselves, we can absolutely shape and challenge the decisions of others, both inside and outside of the council, by asking the right questions, gathering evidence, and making recommendations. You'll also see in the report the specific responsibilities set out in our terms of reference. So these include scrutinising how local health services are commissioned and delivered, working to reduce health inequalities, and holding our Health and Wellbeing Board to account. Importantly, we also have a duty to respond to our consultations from health providers and to work closely with partners like Health Watch Northamptonshire and the Executive Member for Health and Social Care. It's worth mentioning that up until the 1st of May this year, we were also responsible for scrutinising the council's role as an education authority, but that responsibility has now moved to the new Children, Young Persons and Education Committee, which allows us to concentrate fully on health. A key theme across all scrutiny work is that it only works well when members are informed, prepared and confident in these issues. So there will be support and training available to help you build those skills, and I'd really encourage you to take up those opportunities. Before I finish, I just want to touch on why your work here really matters. So the health challenges facing our communities, whether that's access to GPs, mental health services, social care pressures and health inequalities, are complex, and no one organisation can solve them alone. So your scrutiny role provides a vital democratic check and balance, helping to make sure services are accountable, transparent, and ultimately better for the people we serve. So thank you again for stepping into this important role, and I look forward to working with you all over the coming year and supporting you to make a real difference. Any questions?
No questions. Thank you for that, Raj. We'll move on to item number 5 then. Northamptonshire Integrated Care Board introduction from Toby Sanders.
Thank you, Chair. Good evening, and thank you for the invite, members, to be here with you today. My name is Toby Sanders. I'm the Chief Executive of NHS Northamptonshire Integrated Care Board. I'll say a little bit about what that is in a moment. I'm also joined to my right by my Chief Medical Officer, Ginny Nelson, and we're going to do a little bit of a double act for you this evening. That sounds far more rehearsed than it might come across, but we'll get to that in a moment. So I think that the purpose of us joining you this evening, and it's actually great to be here with you as well with colleagues from our acute trust and also our community and mental health trust provider as well, Actually in the room, quite uniquely probably this evening, you've got the kind of collective leadership across a number of our health services and commissioning across Northamptonshire. So I think a good opener for many of you who are new into this committee and space. So keen, as we said in pre-conversation, Chair, to allow time for conversation, any questions you might wish to put to us. But if you thought it might be helpful, just almost take a little bit of a step back to kind of who we are and what we do as an organisation. And then I'll ask Janine to just bring to life a few of the bits of work that we're involved with. We've got a more detailed slide deck, which is more of a kind of read piece, actually. So we're happy to circulate that if that's something we can do afterwards. And you might want to pick through some of those bits and come back to us separately. So we'll leave the screen as it is, if that's okay, for a moment, and I'll just say some opening kind of pieces and then to Janine. So the Integrated Care Board that I'm the Chief Executive of is the bit of the NHS that's the commissioning part of the system. So it's our job not to directly provide services. I'm really glad that we've got colleagues very ably to the right of us, general practice, community pharmacy and so on, that do the direct provision piece. Our bit of the system is responsible for planning and funding and overseeing the quality of health care services across Northamptonshire. So we're county-wide, we cover the whole kind of 850,000 population across the county, and we receive an allocation from government via NHS England on an annual basis to fund pretty much all of the health and care services that the NHS funds across the county. So the total budget of my organisation this year is just a bit over 2 billion, 2.1 billion in terms of that level of funding, and that funds pretty much all general practice, community pharmacy, dental services, significant proportion of our acute services that are delivered for our Northamptonshire population, community mental health services, a range of voluntary sector organisations who support the work of our statutory bodies, and also we fund care placements and continuing health care for those of our population who need ongoing support in terms of either residential or domiciliary home-based care as well. So a very, very broad spectrum of services that we're responsible for commissioning on behalf of the population of Northamptonshire. But we're not a large organisation. We employ less than 200 people. So as I say, we're a commissioning body, a planning body, rather than a direct provision organisation. We are physically based in Northamptonshire. Our headquarters are in Kettering, actually in one of your buildings, I think, in Haylock House. So we've got a main office space there for our staff and teams. We're governed and run by a board, which is made up of an independent chair, myself as Chief Executive and an executive team. We also have a number of non-executive members on that board, and they provide independent scrutiny into the work that we do as an organisation. And really importantly, we have partner members as well who are full voting members of our boards, and that includes your Chief Executive here, Adele. It also includes Anna from the West Unitary, as well as partner members from our NHS trusts and from general practice. So we're very much a partnership organisation. We bring together different parts of the health and care system, and it's that responsibility around setting out outcomes that we need to improve for our population. So we work really closely with your public health teams, with your adults and children's services, identifying the really important things we need to do something about to improve health outcomes, and in particular to address inequalities across our county for our patients and population. Commissioning and contracting those services with providers who ultimately deliver on our behalf, and then working with them to make sure that we're seeing that delivery as we go through the year, whether that's on access, on waiting times, on quality of care, on workforce development and so on. And then sort of feeding that back through in terms of that commissioning cycle, in terms of evaluation, review, and looking at the evidence base of what works well. So I often describe us almost as the glue within the county. We're the part of the NHS that brings other organisations together. It's our job to work with colleagues in this room and local authority colleagues to make sure that we've got the right plans in place for our population, and that we're commissioning alongside those as well. We also have a number of statutory duties which, again, particularly bring us into close working relationships with local government. So we're a statutory partner in relation to SEND, for example, which I'm sure your members will have kind of been briefed and brought up to speed with some of the issues and challenges across Northamptonshire. But also we have statutory duties in relation to areas like safeguarding and a number of other functions where we work really closely with council officers as well. So it's good to be here with you this evening. I'm very happy to take the conversation information wherever you might be interested. I also note that your scrutiny officer's got an item later on the agenda on your work programme, and again, very happy to feed into kind of how we help in your opening piece, Raj, around making sure this committee is informed and has got the information it needs to be able to do its job effectively. If I may just bring Janine in briefly to highlight, perhaps bring to life a few of the practical things we're involved with at the moment. Janine, over to you.
Thank you. Sorry.
That's right.
And on one. Oh, next few. I think you've got the longer version. And the one after this one. Yeah, thank you. So I think Toby's explained what we are as an integrated care board. I thought I wanted to give you a little bit of a flavour for what our priorities are and our work programmes over the next year and beyond, and a little bit of understanding of also some of the very specific work that we've been doing in Northamptonshire with our partners. So I'm sure you'll all have seen the press around the NHS 10-year plan overview with the three main themes of analogue to digital, treatment to prevention and hospital to community care, with a really big focus on neighbourhood health service expansion. And actually I'm pleased to say that as an integrated care board and wider system, actually this isn't anything new to us, and these are principles that we have all been working together across the Northamptonshire with a focus over the last few years anyway. So these are things that actually are very much part and parcel of what we do in a normal working week. Next slide, please. And the next one. So we have a number of focuses as an integrated care system. So we have a 10-year shared vision, which is obviously that we want to make Northamptonshire a place where people are active, confident and empowered to take responsibility for their health and well-being, with good quality support and services. We've got a number of aims, which won't surprise you. They're to improve our outcomes in our population health and healthcare, to tackle inequalities in outcomes, experience and access, to enhance our productivity and value for money, and to help the NHS support broader social and economic development, which is something that is very key when we're working together with our local authority and public health partners. We obviously are underpinned by a number of national priorities. We have some multi-impact interventions that we're specifically working on around digital, recovery of independence, service access, particularly children and young people, and end-of-life care. And we have a number of delivery partnerships where we all work together as system partners in order to pinpoint specific areas. So maternity and neonatal, children and young people, primary and community care, urgent and emergency care, elective care, so that's planned appointments and operations, cancer care, mental health, learning disability and autism, and palliative end-of-life care. Next slide. So we have a number of priorities in 25-26, and these priorities are that our strategic priorities will be enabled by high-quality data. So we work very closely with public health on getting population health data, so we understand our populations and we understand what our populations need in terms of healthcare. And we work very closely to have joined up information and clinical systems, so we have something called the Northamptonshire Care Record, which enables all of us to be able to see patients' health records and very soon social care records across the county, so that we can all access the care records for each individual patient as we see them. We work very hard on efficient care, so driving care into the most appropriate settings, so that's to ensure that not all the time do patients need to go into a hospital to have their care, that their care can be either home-based or community-based or within their neighbourhood, which makes it much easier for them to access. And we're very clear that we set a set of outcomes that we're all working towards together, and metrics, so that we're all delivering those three aims and those three shifts in the plan. Next slide. Some of our work programme for the coming year and ahead is that we're working very closely with colleagues to deliver integrated neighbourhood care. So we have a new models of care programme which is largely focused on same-day access, so improving that same-day access to care, but also ensuring that community-based services are where patients can access them. So we're going to have 2 innovator sites in the first instance from our 9 neighbourhoods across Northamptonshire, and then we'll be testing and working through our model of care to make sure that that's the most appropriate care for our patients, most appropriate care for value for money, and then with a view to rolling that out over the following years across all 9 neighbourhoods. And that will mean that GP practices will be able to see patients who have more complex needs that they need to see a GP with, but those patients with low complex health needs will have better access on the same day. So with a view to stopping those queues and that around the GP surgery or the rush to try and get on the phone and hanging on the phone for hours, in that we'll produce a model within the neighbourhood that supports making that much easier for patients. We also have a lot of work going on, next slide please, with urgent and emergency care, and we have a multifaceted approach to that, which includes empowering self-care and active prevention in our patients, and that's where we work very closely with our colleagues within public health. That patients, as we've spoken about, can get more rapid access to primary and community care, that we have urgent community response services so that when patients need care and may be able to get that care at home, so they don't necessarily have to go to an urgent treatment centre or a hospital, that healthcare can come out to see them at home and make sure that they're then directed to the most appropriate place for their care. Obviously, our working closely with our colleagues in the acute trust for around urgency and emergency and acute care to make sure that they can access that in the most appropriate way, and that isn't always via A&E, but also then supporting our patients at the other end to make sure they're coming out into the right care in the community preferably, and that we have home as a first destination for them wherever possible. Next slide. We have a very key focus on children and young people, as I know you do in the local authority, and we have a number of programmes over 25-26 that we're committed to delivering. So one is the commissioning of a lead provider model for community services, so that all our community-based services are under one lead provider. A number of programmes that are focused on improving children and young people's care, working in partnership, particularly for SEND, across all of our partners. And again, we have a number of programmes in place to improve the healthcare for those children and young people with SEND, and also ensuring that we're working in partnership to ensure that children at very early ages, at the 2.5 year health review, have an increased proportion of children that are accessing that, because we know that the younger it is that we get in to see children and improve their health and make sure that they are having early identification of any developmental needs, the better their health in later life is going to be. Next slide. We're also very keen to improve access to services, and again we have improvement plans, as we shared at the Health and Wellbeing Board last week, to improve access not only to primary care as in GP practices, but also to wider primary care for terms of dental access, and also some particular programmes around optometry. We have a plan to deliver elective recovery plan, so that's to make sure that patients are waiting for as least time as possible for any elective procedures that they may need, and obviously working very closely with our colleagues at NHFT around the transformation of mental health, learning disability and autism. Next slide. It won't surprise you that what underpins all of this is a digital roadmap in order that we can ensure that not only do our workforce have expertise and ability to use digital tools and the best digital tools that they can to improve care, but also that our patients and our population are empowered in order to be able to access and use those services, but that we don't leave behind any population that can't, for whatever reason, access digital services in a timely way for them. One of our main priorities is tackling health inequalities. We have a health inequalities and prevention group that's co-chaired across the ICB, myself and the 2 directors of public health from the local authorities, that reports into both the Health and Wellbeing Board and the Quality Committee. We produce an annual report as an ICB that's published on our website, which gives health inequalities information, metrics, and also the programmes that we have in place to improve our health inequalities. And as I say, we work very closely across the system with all partners, including the VCSE that are represented in that health inequalities and prevention group, to improve as much as we can the health inequalities of our population and to focus our work in that area. We've had some really good work done with some of our populations, in particular our Eastern European populations and our racialised communities, where we've worked very closely with them, with VSE and community partners to try and improve their access to care. Next slide. We also work very closely on tobacco dependency and weight management and have a number of programmes in place across both providers and public health and with primary care in order that we have a focus on those. Next slide. We've also got ongoing work in North Northamptonshire with cancer screening, but also with HIV peer support, which operates out of Kettering. And again, that's just some further information about our award-winning work with Eastern European population, which was a pan-system piece of work, which is very important because in Northamptonshire, our highest ethnic population is our Eastern European population. We've had a lot of work done around working on what we call our core 20-plus connectors, so that's empowering individuals who work within the community to be able to give those health and equality messages to the communities with which they work, and that's included a whole load of work around developing resources, both visual and written resources, in a number of different community languages that are relevant to our own communities. Next slide. And the next slide. So we've got a busy year ahead in 25-26. Much of that work we'll be sharing at the Health and Wellbeing Board as we work through. So we're aligning our health and wellbeing strategies with North and West Northamptonshire. As I've described to you, we've got a number of priorities. Obviously, we have a new government and the 10-year plan in place, so we'll be expecting potentially new pieces of work to come out through the year that we'll be working through, and also some changes potentially in how ICBs work, in that we may well be working in more of a clustered way to share resources with Leicester, Leicestershire and Rutland as the year moves on, but more detail of that will emerge over the year. We haven't quite got all of that information yet. So I'm happy to take any questions.
Thank you, Toby. And was it Janine?
It is Janine.
Thank you both. Thank you both. Good double act. Over to the members now. Any questions? Harrison?
Thank you, Chair, and thank you, Toby and Janine, for that whistle-stop tour of the huge amount of work that you guys do. Prior to the meeting, we had a bit of a think about some of the questions we might want to ask you, and of course, some of them you've covered to a degree. So the first question we were going to ask you about was about your priority programmes to reduce health inequalities, and you have covered quite a bit on that. So I just wonder if you could perhaps give us a bit more detail on how you're sort of focusing on two separate communities, our most deprived areas, and also our rural areas. So that's our first question. The second one is about how the ICB is supporting integrated delivery of primary care, community and mental health services, and how that aligns with the local area partnerships. And again, you did cover quite a bit of that. And I was really interested when you mentioned the 2 innovator sites. It'd be quite nice to hear a bit more about that maybe. And then finally, just a bit about how you're coordinating efforts to address emergency care pressures. Now, again, you did say quite a bit about that. I wonder if, I mean, an obvious thing that's on the horizon, we hope not, but is the possibility of doctor strikes. So I wonder if you could perhaps tell us a bit about how you're maybe planning for that unfortunate eventuality if it happens. Thank you.
Sorry, Janine, do you want to press the button on the microphone?
Sorry, yeah. So I'll take the first question. I wonder if the rest of it is better taken when everybody's spoken, because some of that information may come out in the other talks from the other presenters, because obviously we all work together as one system, so they're not just things that solely we would do as an ICB. So in terms of working with the deprived and the rural communities, one of the things that we do within our data is that we look very closely at our population health data. So we will be able to tell you for certain conditions that we work on a priority programme called the Core 20 Plus programme, which is a national programme which identifies specific medical conditions and specific populations that we need to focus on. So all of our population health data is split so that I can tell you the differences between the most deprived communities and the least deprived communities in Northamptonshire and grades in between, so it's kind of a scale of 1 to 5, so that we can see for any health condition at any time what the difference is and where we need to focus, and that helps us to plan our work in the year ahead. Within that, we can look at rural communities versus non-rural communities. That's within because we can search on postcodes, and we have something called the Northamptonshire Analytical Reporting Platform, which is a population health and data tool that allows us to take all the health and care data that we can get from around Northamptonshire, put it into that tool and come out with all of that modelling to tell us where our populations are, who needs what care. It's quite unique to Northamptonshire, and it has been really well commended by NHS England as a really good tool, and the being able to bring social care data into that has really helped us with that. That data then underpins the services that we commission, so that when we look for what healthcare we need to commission, we've got the data around where we need to place that healthcare and for whom. As we start to develop more as strategic commissioners, which is a slight change in role for the ICB, we've always commissioned, but we're required this year to become more strategic. We'll be using more and more of that data to underpin which services we provide. Health inequalities runs through everything we do, so when we sit down every year and review our services, what we do is we look at the health inequality outcomes for all of our services. We've just gone through all 500 of our contracts at the end of last year doing just that, and to see are they doing the right things for the right populations that we serve. So are we addressing with the services that we commission health inequalities? Do we have that information to show that we are? And then in terms of a little bit more about the rural access, obviously in terms of looking where we're placing dental appointments or same-day access or neighbourhood hubs, then clearly access to those services is something that we look at very closely, and that's also something that we look at when we look at the health inequalities with each service that we commission. I chair our community engagement panel, and obviously access to services comes up an awful lot from the community, as you would expect, especially those in rural communities. In terms of the 2 innovator sites for neighbourhood health, we haven't actually chosen those yet, so there will be a procurement exercise. But obviously I think our vision is to have one in the west and one in the north, Northamptonshire. And obviously, again, there will be criteria around that to make sure that those sites are placed hopefully in places where there's most need. So I could talk all night. In terms of integration with mental health services, in terms of urgent and emergency access and managing the doctor strikes, I think probably best if my provider colleagues speak first, and then we can take any remaining questions at the end.
Thanks. That's really helpful. Do you mind if I just come back a little bit on the sort of rural part of the question? So, obviously, I serve a rural area, and one of the things that I always worry about a bit, and I do hear that you are getting data about what is lacking in rural areas and the access problems. But one thing that always worries me is when you look at data about where the greatest need is, we often know where the greatest need is. It's where larger populations are generally, and usually in more deprived communities. But all of our rural areas also have pockets of deprivation, and those pockets of deprivation in our rural areas usually find it even harder to get access to services than you do if you're in a more urban area. And so and because they're much smaller pockets of, of populations, I was worried that when you're thinking about the best bang for your buck, how are you going to improve outcomes? It's easier to place your services where more people can access it, and therefore rural communities can often feel or appear to get somewhat left behind. So I'm sure I know the answer to this, but it's probably no. But I was wondering if, in thinking about your two innovator sites, obviously one in West, one in North, would it be worth looking at one that's trying to serve a more rural population versus one that's trying to serve a more urban population, so that you can look at how those two models work differently wherever you choose those to be?
There certainly will be a lot of factors that we take into account when we choose those two innovation sites. Some of it will depend on who comes forward wanting to be those innovation sites within the primary care within those areas. But certainly ensuring that we've got a breadth of health needs across those two sites will be important to us. So yeah, and I know that our community engagement partners will remind me of the rural issue, as they frequently do in meetings. So it won't be forgotten. Thank you.
Councillor McLean.
Thank you, Chair, and thanks for the presentation. Most of the stuff that I was going to ask has been really covered, but there was a few sort of left field sort of questions I've got, in the sense that I live in Kettering, but it's quite a sort of retired area, and what I find with my neighbours is they don't want to bother people. How do you reach out to these people who don't want to bother people, like the doctors or anybody, and try and bring them into the fold when they may have problems but they're not being addressed because they don't want to bother people?
I think that's when it's really key that we work either with community organisations with whom they would naturally tend to, so whether that's be working in community hall settings where they may go for other groups, whether that's working with organisations that they may come across in other ways, not necessarily health and care, such as Ageing Well, for example. And we do work with a number of our VSE partners to make sure that we try and have as much in-reach into our communities as possible. We also use the resources of our public health and local authority colleagues who are very well connected within communities to do so. And I think it's always been conscious that not one way works for everybody, so digital is a great aspiration to have, but may not necessarily be the way for all of our patients, and may therefore sometimes put barriers in the way of people if we're going to go all digital. So it's making sure that we have ways of including all populations. We do have a very large number of retired participants in our community engagement forums, and we do also work very closely with the GP practices and their patient partnership groups who feed into that. But I think it's that trying to reach out to the community in different ways and make sure that we are working closely with other partners who may have more of an insight into those communities who aren't accessing health and care.
Toby Sanders,
if you wouldn't mind, yeah, just to add, I think that there's almost a bit of a link for me as well between part of the two questions, which is around, in my language, kind of loneliness and social isolation, which is, and that impacts on how people access service and how people kind of come forward, whether that's from the rural issue that's then compounded in terms of transport and geography, or whether it's urban areas where people can be just as isolated and lonely, living kind of metres apart from each other. I think for me it's where the local area partnership bit and the neighbourhood services piece becomes so important. So the work, and I'm sure David will probably touch on some of this from a community services perspective as well, that we do in local areas, which does bring together GP practices, primary care networks, community nursing teams, adult social care teams, and really importantly the voluntary sector. I had the pleasure to visit the SERVE team here just nearby a couple of months back in terms of the work they do through some of their community centre access. What they do in connecting with local people and providing contact and providing befriending support for people throughout different times of their life. Huge impact in terms of keeping people well and avoiding some of that kind of isolation piece. And that's non-statutory service provision in many cases. And it's those kind of networks that from a local point of view You'll hear us talk a lot about neighbourhood services over the next few years. It's a big push from a national policy agenda. And actually, there's some really quite exciting opportunities coming on the horizon around early pilot sites across parts of the country on this. But I think that neighbourhood services bit, where we get into a much more local level, that's where we look to our primary care teams who serve those particular populations. They know their health needs and issues. We look to our community teams that work in locality footprints. And that's where I think you start to see the tailoring of some of those service offers. Thank you.
Thanks for that. Just another thing associated with the integrated care. I noticed when picking up a prescription the other day, the pharmacies are offering even more services now. Is that something that's going to be included in the future?
Yes, absolutely. So the pharmacy team sits under ourselves at the ICB and the medicines management team, and a lot of the work that we do is working with community pharmacists to improve the range of services that they offer. So that's a whole range of basic diagnostic and prescribing services. So, for example, if you've got cold or flu symptoms, earache, you can now go in to see a number of pharmacists who will manage that, and that coverage is increasing. They also are very key to working with us, so that we've got programs where they're starting to look at those patients who've got cardiovascular risk factors, which they get from the GP records, and then as a pharmacist they can see that patient and prescribe what's necessary to support them to reduce their cardiovascular risk factors. So really helpful within a lot of the prevention work that we do. Obviously also increased rollout of vaccination through our pharmacists. Again, often they're more accessible, they can do walk-in services, and they're located on people's high streets. So absolutely the role of, I think, our pharmacists, also our other services such as optometrists, and we're also looking not only at dental access but also what wider oral health services we could do from dental platforms as well.
Thanks very much for that. It's funny you should say the dental. It was a dentist today, and she's still less than pleased with the package that they've got.
Clearly, so that's a national package that's not determined by ourselves. We have worked very hard to, and will be working very hard over the next year to increase the number of dental appointments that we have available. We've had a number of schemes, as we discussed at Health and Wellbeing, to try and attract dentists into Northamptonshire and improve the dental coverage, and also working very closely with our colleagues in public health around oral health and prevention of dental problems, because clearly working to do that for children and young people, with a number of the schemes that the local authority and public health have in terms of teeth brushing in schools and healthy eating is essential, so that we manage to stem the flow of people needing urgent dental appointments as time goes on.
Thank you very much for
that. Councillor Howes.
Thank you. I've got a few questions as well, and forgive me if you've covered them already. What areas of the ICB's performance are currently under NHS England oversight or subject to formal improvement planning? What action is being taken to improve performance against national standards in elective care, cancer waiting times and access to primary care? And where does the Northamptonshire ICB sit in terms of national ranking standards? How is the ICB addressing the challenges of system-wide financial sustainability, and what decisions may impact local services in North Northamptonshire?
Go ahead.
Wow. All brilliant questions, and probably all of them kind of merit a much deeper conversation probably than we've time to cover tonight, and that might go a bit back to your kind of future work programme. I'll touch on a couple of those if I may, and I'll also look to colleagues as well, particularly in terms of kind of urgent emergency care, perhaps the electives and the cancer side of things from an acute perspective. In terms of kind of the oversight framework we work to within NHS England, so nationally published oversight framework that reports integrated care boards and also then separate reporting in terms of NHS provider trust position against a whole series of those metrics that you've described. Our relative position across Northamptonshire, and I'd emphasise relative, is reasonably well placed against a lot of those different measures, but, and just to be really clear, that's against a relative position in a whole host of areas where the NHS in general is not where we'd want it to be. So if you take something like urgent emergency care, for example, and A&E for our performance, our our A&E performance across our 2 acute sites benchmarks relatively well to a lot of other parts of the region and the country, but that is still not where we'd want it to be in terms of an overall standard position. From an elective perspective, that's been an area of real strength actually from a county position over the last couple of years, particularly coming out of COVID in terms of wait times. We've made very good use of the independent sector locally. Our challenge, to link to one of your other points around financial viability, is how actually do we kind of manage some of the use of other independent sector and out-of-county providers in order to deliver as much activity as we can within Laura's 2 hospitals locally that are kind of core NHS funded, whilst maintaining that relatively decent position in terms of elective. In terms of our financial context, that's probably the most challenged actually out of all of the kind of areas that you sort of worked through, Councillor Howes. If you followed the NHS locally, you'll know over the last couple of years that as a system collectively, we've spent more than the allocation that was allocated to us. In terms of our plans for this year, we have or are in receipt of additional national funding to the tune, I'm going to say 55, I think it's 65, thank you, million in terms of additional funding on top of our allocation. So each of the different parts of the NHS has set out its plans. They've been supported and signed off by NHS England. That's the regulatory body that oversees us. But delivering against those is going to be a real challenge in year, particularly, again, that I'm sure acute colleagues might want to pick up in terms of the cost base within our acute hospitals, our 2 DGHs, and some of the pressures that they see, particularly around urgent emergency care, access, length of stay and waits. So there's a lot we could kind of get into in more detail. If there are particular areas, I'm happy to try and tease those out. I'm very comfortable to come back perhaps with another colleague and do a more detailed bit on the overall performance framework. I think I'm right in saying, looking at NHS colleagues, that the new national oversight framework, we thought it might have been coming out next week with the league table reports across the country. I think that's more likely now, I understand, to be after summer recess. But once that material is out in the public domain nationally, more than happy to come along and do perhaps a more detailed dive through some of those areas. Thank you.
Thank you.
Thank you, Councillor Howes. Councillor Pengelly?
Yeah, thank you. You've talked about health inequalities, and Helen mentioned about rural issues, which are very, very important, and the breakdown of areas in rural estates in rural areas have got these issues. We've got these new super wards now, and what you do, you do a lot of the figures, and I saw at the LGA conference, a lot of the figures are based on wards. And what happens if you've got a super ward, issues where you've got areas of deprivation are then diluted by these other parts of the wards. So where we used to get money through SRB and other things in Corby, that may not happen because everything looks rosy. So how do you identify issues where there are in certain areas of the town that need more support and more people going there and giving people advice? The second part is you spoke about the smoking issues. I heard that same thing said 30 years ago. I heard that same thing 20 years ago and 10 years ago. We were always 30% above in Corby, above the national average. Have we failed, and I say yes as well, the people of Corby, because we're not tackling the smoking issue in Corby, especially with young females. So why is that? Why have we pumped so much money in? I saw Northamptonshire got all this money the other year, last year, it was in April last year, to tackle smoking. I've not seen much as a councillor in Corby on that. I know it was mentioned at the one of the boards a month ago, but I've not seen much myself. So what we're doing there, and what I always get told, and I said this about 20 years ago, and I'll say it again: if you stand on the top of Rockingham Hill and you look towards Rutland, you live 10 years longer than if you look towards the Lodge Park estate or the Stevenson's Way estate in Corby. So we die 10 years before people in other parts of the country. Why is that? And why are we not tackling that for the people of Corby? There's a lot of worry about cancer rates in Corby, and I know there's been questions asked to David Watts and others by the press and families and whatever. Is that something you're looking at? Because that is now a worry to many people in Corby. Why is the cancer rates higher? Are they higher? Do we know that? And I think that's got to be tackled as well. And now will that be looked at by this body as well going forward?
Can speak about smoking.
Yep. if I happy to pick up on the first question, part of the question that was around kind of wards, super wards, and the geography point, and then maybe look, if that's okay, to kind of public health colleagues to pick up on the smoking and tobacco control piece. I think you make a really good point, Councillor, about when you start, the bigger the area you look at, everything starts to look average. If you look at Northamptonshire as a whole, which is our overall geography, everything looks pretty average. You kind of, it doesn't really stand out. It's not like if you look at an area like, you know, Birmingham, sort of inner city, for example, where everything kind of stands out the other way. That's why the work that Janine described in terms of the data we look at in terms of population health data is so important, because it drills all the way down to much more local area. So not just looking at ward, but looking at super output area, and in some cases getting right down to neighbourhood and almost street level in terms of the things that we can interrogate. The crucial thing is, what do we do about that in terms of using that information? So it's one thing knowing you've got a real difference across those things, and that for me is the link back into the neighbourhood services work, the local area partnerships work, and in particular at primary care network level across groups of general practices, because that's about the most localised kind of unit that we run out across the NHS from a commissioning point of view as well. So I really agree with you. If you look at things at an overall level, it masks a whole load of stuff within that. It also masks things where we've got major changes in population growth. I mean, that's one of the other big themes I'm really conscious of for Northamptonshire, and actually for North in particular. We've got a lot of big housing developments that are coming through. They will very significantly change those kind of ward profiles, whether it's Hamwood Park or whether it's areas like that over the coming years. And our organisation is responsible for working alongside your planning colleagues and others to make sure that we've got a pipeline of future health facilities coming through that can respond to that need as well. And again, that's one of those things that if you look at the average, you kind of lose what's happening at a much more localised level.
Yeah, go ahead, Shirley.
Thank you. So with regard to smoking, you're right, there are still issues around smoking levels, particularly in some of our more deprived areas, and particularly in, for example, routine and manual workers. So there's a couple of things that public health are doing. Firstly, we have been awarded, as you mentioned, about £500,000 extra for the next 5 years to tackle smoking cessation and to provide support to people who want to quit. So in that respect, we've doubled the size of our team, so we can offer that service out to more people. It's very flexible. It fits in with whether people want face-to-face or telephone consultations. So the other work that we're doing, you'll have noticed in the Health and Wellbeing Board strategy, smoking and vaping is one of our key priorities. And that's not just a public health local authority priority, that's a system-wide priority. So basically that helps shape all partners' work. We are specifically have set up an action planning group to work through all of those activities and to coordinate that across the system, because we agree there is a particular piece of work still to be done around smoking cessation, and I think tackling that vaping as it comes up through young people. One of the other things we've done is working through the local area partnerships to make sure that we're getting the right data, and that more hyper-local data, because you're right, it gets, the bigger the area, the more masking takes place. So there's a couple of ways we've done that through the local area partnerships. We've actually worked with colleges and schools to talk to young people about what their issues are, particularly around the vaping. So we are developing plans and addressing those and working with partners to address those in the longer term. And we've got our Healthy Schools team who are providing resources to schools to help manage that, so that we are tackling it in two ways, if you like. It's that very early intervention and prevention and education piece, but it's also offering services so that if people want to quit, they have access to those services, and there are a number of ways that they can quit, and they are supported through that process.
Any further questions from the members?
I did mention something about the worry of a lot of people in the town right now after Toxic Town and some of the things that have happened lately in the press with the thing down in Parliament last week. People are worried about cancer rates in the town. Are they higher than the national average? Are they caused by soil being dumped in places that it shouldn't have been dumped? People want to know, and when will we be looking at this as a board going forward? Well, it's something that we look at because it's important for the people in the town. They want answers, and I'm here to represent people in the town I live in.
Do you want to take that one?
I think it's precisely the sort of thing this committee should be looking at, personal view, and therefore if there are things that you would welcome, then particularly from a joint public health perspective in terms of a lot of the data from that perspective, and from a health point of view in terms of access to services, very open in terms of engaging in that. There are some of the areas that you've got as a committee on your agenda which are very much service specific. I'd actually encourage this committee from a personal point of view to look at some of those broader questions as well, which actually touch on health and social care and kind of wider determinants in terms of how we work. So clearly you'll look at your agenda setting, but if that's something as a committee and your chair you want a programme to work with, then we'll work with you on that.
Councillor Pengele, would you like to propose that as a future area for scrutiny? Seconded?
Oh, second.
Yeah, seconded by Councillor Lumsden. So we'll pick that up for a future area for scrutiny. Okay. Councillor Harrison?
Yeah, sorry, I'm really happy that we bring that forward. I was just going to say in terms of the data around that, and it's a really obvious question, isn't it, that a lot of people have been asking ever since it came out in the public again after the TV show. But I guess the thing is there are so many different factors that will affect whether somebody develops cancer or not, and if specific areas have higher rates of cancer or not. So the detailed work behind that would need to be done before any of those questions can be asked, because you're going to have to take in all the different variables before you can definitively work out whether there are higher rates or not compared with similar populations with similar types of challenges, I guess, is the thing. So, if I can just say that can some work, I guess it comes down to public health, really. That's where the data is going to be analysed. It probably wouldn't be very helpful to bring it back until there is some data to be looked at, I guess is what I'm trying to say, clumsily, but yeah.
David Watts.
Thank you, Chair. Can I suggest that we raise it with Jane, our Director of Public Health, when she returns from leave, and perhaps she could provide a bit of an update from her perspective as to a proposal that may work for health scrutiny rather than adding it to the forward plan at this point. Raj, we normally keep a sort of list of future items which aren't on the actual forward plan, and hopefully Jane would then be able to give you an indication of the time to undertake any work, so that we're not bringing you to scrutiny without having the full data set and the full information to enable you to understand that.
Chair, sorry, I've got to disagree with the officer. I agree you have to get
Thank you, Councillor Pengele. We're going to go to the Scrutiny Officer, Raj Sahal.
Yeah, so as David mentioned, the item will be added on the items to be scheduled. Then once we talk to Jane and we know when we can get an indicative timeline, we can then attribute that to an actual meeting and have that on the forward plan. David, did you want to add anything to that?
No, I was just going to say I hadn't said don't put it on the forward plan. It was let's not give it a date yet. Let's get a steer from Jane as to how long it would take to undertake that work. So apologies if I was misleading Councillor Pengele.
Okay, now we're going to move into the proposed holding recommendations. Recommendation number 1 is the integrated care delivery and place-based planning. It is recommended that the ICB returns to the committee with a detailed update on integrated service delivery in Northamptonshire, including alignment with local area partnerships and support for prevention and early intervention services. Number 2, regarding primary care and growth area planning, it's recommended that the ICB presents a forward plan for ensuring sustainable access to GP, pharmacy and dental services in areas of housing growth and high demand across Northamptonshire. And then the third and final one is system performance and regulatory oversight. It's recommended that the ICB provides the committee with a summary of areas where NHS England has placed the system under enhanced monitoring or improvement oversight, including actions and recovery plans. Catch all of that?
Raj will send that out to us.
Yeah, I'll forward those recommendations to you following the meeting.
Thank you.
Thank you.
Any further questions from the members? Councillor Geary? No? Okay. Toby and Janine, thank you for your time. We're going to move on to the next item on the agenda, which is item number 6, NHFT, Northamptonshire Healthcare Foundation Trust, with David Mayer.
Mayor's fine, thank you.
Thanks, David.
Evening, everyone. I'm David Mayer. I'm the Deputy Chief Executive for Northamptonshire Healthcare Foundation Trust. So I've got a few slides. I think they've gone out, Raj, or they will go out to colleagues. I won't try and read them off that. I'll leave you to do that, and I'll navigate here. So as colleagues have said here, there's a commissioning framework, so the story of kind of public resources coming through from Treasury through to Northamptonshire. We provide to the county a set of community services, including district nursing, school visiting, school-aged IMS, etc. We also provide mental health services on behalf of the county, and we also provide a number of secured services across the East Midlands, which are national services in that sense. We also work in a group with Leicestershire Partnership Trust, so very similar to the leadership model for University Hospital Northamptonshire. Working with University Hospitals Leicester, we work with our counterpart in that geography, and that adds real benefit to our ability to particularly recruit a really scarce resource. Psychiatry is under quite as all parts of the NHS are, but psychiatry, speech and language therapy, all of these services that we provide do have significant challenges in recruitment locally. So the bigger a footprint we can operate on, the more attractive we are to colleagues who want to join a wider kind of NHS family. We take great pride in providing cradle-to-grave services. Quite a number of our young people and families will have contact with our early years services. Some of those individuals will need our mental health support over the course of their life, and some of them will need our palliative end-of-life care at the end of their life. So we do generally see a full kind of life course of the population across Northamptonshire and indeed the county. And that cradle-to-grave model of working is really kind of foundational to our identity in terms of how we see ourselves supporting the wider social fabric in Northamptonshire. We've got a rich kind of range of services, over 200. We've got about almost 100 different registered locations. So again, that identity of cradle to grave mapped with deep community roots based in real all localities in our geography is again foundational to our identity. So Raj, if you just go on to the next slide. So I talked about the healthcare model of working, and I know Laura will probably touch on some of this in terms of work in more specialist services in the acute sector. But in 2019, we started a buddying arrangement with Leicester Partnership Trust, which then moved into a formal group partnership arrangement. And we've been working on a university status, so we would be a university foundation trust. And again, that widens our reach and impact in terms of research, particularly mental health research, and we've done some good work on loneliness, which Toby referenced earlier, in terms of our frail older population, because that is a significant demographic driver for us in Northamptonshire, with well in excess of kind of national benchmarks in terms of older adults coming into needing support over the next kind of 5 to 10 years. So the university status gives us another way of thinking about how we provide services in a deeper, richer way for the demographies that we serve. Earlier this month, we launched our first group strategy. So that gives us a framework now to do planning collectively with partners in Leicester. And it's an evolution of our DIGBQ strategy, which this committee, possibly Councillor Harrison and others may be familiar with, but new members may not. That framework is called Thrive and is modelled on technology being T, H for healthy communities, which is where we see neighbourhoods and local area partnerships being enshrined. Responsive, so that's very much aiming at excelling in terms of access and waiting times, and particularly meeting needs as outlined by colleagues in relation to increased prevalence in certain community groups. I for including everyone. We're very proud of our staff survey as an outstanding trust. We've got pretty good morale scores against some of our peers, and that again we know has a direct impact on outcomes for healthcare. So that's including everyone both in terms of a team, but also including everyone in terms of reaching communities that we may not be able to reach or see. V for valuing our people, which I've touched on, and then efficient and effective being where we land some of the challenges that Toby and Janine talked about with financial resources and increasingly a greater emphasis nationally on productivity, so making sure that services are delivering kind of really high volume activity, which we're under significant kind of scrutiny to make sure we do that, and we welcome that scrutiny. Thanks, Raj. So I've talked about deep roots within our community, and we think about our strategy in terms of our people, our place, particularly in this context, Northamptonshire, and then partnerships, and I'll talk a little bit about each of those in turn. So in terms of our people, we've got about 5,500 staff. We are about to take over a number of secured services in the East Midlands in the coming months, which will probably increase that by about 10%, so that's an additional 500 staff. They will be, of course, across a wider geography, so not necessarily based in the county. But we do and are very proud of our local recruitment, with 91% of our staff profile coming from within the county. We spend about 21% of our procurement spend is locally based, which again, we want to increase. That's above kind of national measures. That's, quite a lot of it is procurement related supplies, but we do want to grow that, particularly thinking about our food, our canteen services, etc., how we kind of stimulate the local economy by using the power of the public purse and the public resources that we get. So that's very much part of our plan, and that's the social value agenda that we're committed to. The place agenda we talked about in terms of the local area partnerships and neighbourhoods, but that really is the new exciting opportunity for us. And I joined the NHS when polysystems were being described. Colleagues who've been involved in health policy might recognise those, but they were the first Lord Darcy definition of neighbourhoods were these polysystems which were intended to bring multiple resources together to define health outcomes. And that was 15 years ago, and now we have neighbourhoods, which is a further policy initiative to try and drive that. And I do feel like there's an unfinished business, certainly in me, to make that a reality where we can realise really vibrant neighbourhood services. I'm also really pleased in terms of our place that whilst we've got work to do in improving the fabric of our estate in Corby, we do generally, where we have older estate, have pretty good quality older estate. St Mary's in Kettering is listed. It's a functional site. It's expensive to run. Older buildings are. But we do also have really new facilities on that site in St Mary's that members of the public may not see because they're actually behind the front facade. So I feel the neighbourhood place agenda for us is it's begun, and it will start and continue to grow as a really vibrant part of the way we make a contribution to local places, and consistent with where we see need, because we know that where I live in East Northants, the population there is radically different from 7 miles up the road here in Corby. And again, it's increasingly different down in Kettering, and a different level of need again in Wellingborough. So that place-based, deep-rooted work is really important, with local people being able to make a contribution to outcomes for their communities. And then the partnerships element, we've done, and again, Toby talked about the Mental Health Collaborative, and I'll talk a little bit about that in a second. We believe collaboration really is the way for public services to thrive in a complex environment, and we're doing really great work with partners in mental health, with a number of the voluntary sector organisations in the county supporting our work in mental health. And we would not be able to provide health outcomes without the input from the voluntary sector. It would not be possible to do what we do without their contribution. And we see more of that contribution coming to light in our physical health services, particularly thinking about support for palliative care and end of life. That's increasingly where we see some real impacts for communities from using our partnerships with the voluntary sector. Thanks, Raj. So this schematic gives you a sense of the neighbourhood model, with kind of services based in a locality similar to what we might have in, say, Mary's in Kettering, and then concentrically running around that at differing levels of intensity are support services for individuals, with inpatient hospital-based services on the very outer ring where there's most intensive need. And we do operate, Lord Nigel Crisp, who was a chief exec in the NHS, wrote a pretty good book some years ago, described, the title was Health is Made at Home, Hospitals Are for Repair. And we kind of try and model that in our policy approach for delivering healthcare services, where we try and do as much demand management to keep people in their local communities closer to home. That's in all of our shared interests across the health system. So that principle of health being made at home is very much rooted in the model of work that we've put in place through neighbourhoods, and the work we're doing with transformation partnerships in our communities. Thanks, Raj. So just to touch on the collaboration element then, we as a provider take on a set of resources from our commissioning colleagues to run mental health services on behalf of commissioners and partners in the county. So we are the lead provider in the mental health collaboration, which brings together a primary care resource input, a public health resource input, and then the voluntary sector in terms of their contribution to the outcomes. The membership on the right-hand side gives you a sense of the diverse range of providers: Accommodation Concern, Northamptonshire Carers, Relate, Action for Happiness. And back to Councillor McLean's comment earlier about trying to reach people, and Janine's point about using some of these partners to do the in-reach to local communities is really, really important. So Chat, Northants are based in Oundle. They do phenomenal work with local communities, helping them access counselling support, which we would not have the resources to be able to do. We are not geared up to be able to do all of that really, really deep work that is needed in those communities. So again, I can't emphasise enough the role of the voluntary sector in helping us keep that social fabric tight across our local communities. In terms of our mental health teams, we've got a number of community mental health teams based in the geographies that we've described. Just to pull out a few of them, Up Alloy is our work with Northamptonshire Police, where we're based in their control room, helping them triage calls that come through that may have a mental health component, and thus being able to manage need where we find it. So again, that illustrates the kind of the deep roots and the partnerships that we've got in place with other social public sector actors and providers in that sense. Our inpatient units, we've got about 140 mental health inpatient beds. We provide CAMS specialist support on behalf of the region, because again, CAMS inpatient support would be impossible for us to resource just for Northamptonshire. We have to do that as an East Midlands partnership. And similarly, we have eating disorder resources and beds provided by other partners in the East Midlands. So that collaborative way of working helps us resource complex specialist care when needed. Happy to have and extend the invite to councillors to come see some of these sites. The Welland in Kettering, we're very proud of that centre, and really great co-production with users of services in terms of how it feels when you go into it. So it is a calm, homely environment. And in Berrywood, we had Berrywood in Bloom, which is our Northamptonshire, main Northampton, West Northants Council rather, campus, who take great pride in the gardens. And similarly, we're trying to expand some of that in the sites that we've got in Corby and Wellingborough and elsewhere. So we create that kind of nurturing family environment for people who use services. I probably won't talk too much more on those in terms of the mental health services. We can come back to them in questions, I think. Just in terms of adult community then. So these are our intermediate care beds predominantly, and a suite of staff working in a community setting, predominantly managing demand, so managing need at a hyper-local level, so in people's homes, and thus preventing people needing access to hospital. That is kind of one of the main drivers of our integrated care team. We've got about 130 community beds, with increasing beds coming on stream through partnership working with Northants and our local authority colleagues, developing rehabilitation units. So again, step down, supportive resources, rehabilitating people in an intensive way, and then getting them back home to their families and to their communities as quickly as possible, so they don't decondition in inpatient services. Our community resources then operate, these are our community nurses, health visiting. We operate with primary care networks in terms of ageing well. We've got an Admiral nursing service, so again, back to those partnerships and being able to do things with voluntary sector organisations. Again, they make a real difference. Marie Curie supporting us with some CND, and we also have a range of sexual health and specialist services which we are commissioned via public health to provide, and we're really proud again of those partnerships. Again, back to that social fabric component. Thanks, Raj. So on CYP services, again, this is to all of us one of the most important aspects of the collective work that we do, bearing in mind that the children now are the adults and patients of the future. So we have been through a process with colleagues in terms of a commissioning framework for 0 to 19 services. There's a piece of work happening with colleagues in UHN around community paediatrics, which our commissioning colleagues are supporting. But we feel we're getting to a pretty coordinated place now in terms of our support for children and young people, and we do focus on getting the right risk support to people, and then where there is more help needed, there is a semi-stratified way of people being able to access that. We are, of course, working with SEND and our Looked After Children cohorts and part of the SEND improvement boards that are in place across West and North Northants. The underlying link for this video has moved, so the video won't play, but we'll update that for the pack that goes round, so you get a sense of just some of the work we're doing with schools, which was the intention for this segment. Just then on referrals, so we probably see about 30,000 community nursing contacts a month, just to give you a sense of the scale really of activity that's happening in local people's houses and homes, which is where we want the majority of care to be delivered. Our single point of access telephone service, we probably have about 8,000 referrals coming through that every month, which again is quite intensive. And our integrated care, our intermediate care team, so these are our demand management, emergency response services, we're seeing well in excess of national expectations, 80% of urgent response provided. So that's again just an illustration of the power of local communities and the power of networked provision supporting people closer to their homes. In terms of ongoing work with colleagues, we've had good interfaces with East Midlands Ambulance Services. Over the last winter, we were taking ambulance calls from EMAS through to intermediate care teams. That's now kind of a routine way of doing things. We've had to completely remodel how we approach the work, but that's again an illustration of demand being managed at a community level. And increasingly, we're hoping to do much more direct referrals to be able to access diagnostic support. And we're particularly excited by things like the Community Diagnostic Centre coming on stream here in the north. And that again provides a different way of framing support for communities when they need it. Not aligned to hospitals necessarily, but there if they need that level of support. So just thinking about the forward plan, we think the children, young people agenda in schools and neighbourhoods, that model of working might be something we come back to have a look at here, and you may well ask us to come and present some of our work in that space. We think there's probably a greater opportunity looking at the NHS outcome framework on inequalities, particularly thinking about some of the needs that Councillor Pengali and Councillor McNeill described. We can describe some of the work we're doing around population health management, which we think is exciting and is going some distance to managing unmet need. And we'd also value bringing back some of our partners to be able to demonstrate the contribution they make to you, rather than just being necessarily the statutory organisations that come presenting. We'd like to bring some of that to life in due course. So thank you.
Thank you, David. Councillor Pengali, I've got your email, that's fine. Members, Councillor Geary, do you want to start us off?
Yes, thank you, Councillor Gibbs. Thank you for giving up your time. That was a really interesting and comprehensive view. Very much an overview, and I appreciate that. So one of my questions was about how teams work together, but I think maybe that needs a bit more understanding on our parts before that's appropriate. But I've got two questions which I think are worth exploring here now as an overview. The first one is about effectiveness, how you monitor, for example, not only the output, but the quality of that output with people like the crisis cafes, hospital at home models, voluntary organisations, emergency admissions. So that's the first question. And the second one is about the recent mobilisation of 0 to 11 and 0 to 19 contracts and what kind of impacts they're having on the services. So if you can give us an overview, I think that would be useful now that we can drill down later on.
Thank you, Councillor Geary. So the quality of outcomes were measured, so I guess probably frame the regulatory oversight in terms of our contribution in terms of outcomes from a CQC perspective. We're expected in 2019, we're rated outstanding against those measures, so we take some comfort from the regulator in terms of our contribution in terms of quality of outcomes. We then have a set of national outcome measures that we're measured against, which come through from NHS England, so our commissioning regulator. And against those outcomes, we would be probably in the top decile, if not further, in terms of some of the outcomes that are measured through that framework. The ones that I guess where I feel there are opportunities to do more relate to recovery for people accessing psychological therapies. We see variation between different population groups in recovery, so some of the model of inputs work for some communities but not all communities, so there's further development work that we're doing in that space. Our crisis response, I feel pretty confident, and again rely on colleagues to provide some feedback in terms of our urgent response in our intermediate care teams. Again, we exceed the national expectation in response times there. Our crisis response we measure partially by reduced admissions, so we're keeping people's needs held at a community level, and we do see we have good PREM, which are our experience measure outcomes for people accessing crisis services, and we don't see our crisis response teams being mobilised for untoward events that we would not have foreseen. So where we have needs identified with individuals, we have plans, and we're not seeing those deteriorate. I think in mental health services more generally, there is a wider need for us to develop outcomes that matter for local communities, so we're able to define what matters for local people. And the reason that's helpful for us in Northamptonshire is that we do have that collaborative framework to be able to do that work. And one of the things they did when they were established very early was establish a set of I statements, so what people want when they access services. So I want to feel safe, I want to feel heard, I want to have my needs met within a certain time frame that matters for them. So we do hold ourselves to account for that, and our quality committees review those on a monthly basis in terms of feedback from patients. And we've got a provider called Equivia that provide our patient experience. They go out and they ask patients for feedback, and we collect that, and that forms the basis of our assurance mechanism in terms of outcomes across experience and quality of care. But I think, as you say, it's probably a more focused bit on outcomes that we can bring to illustrate some of the exploration you wanted to take with integrated working across teams, because crisis response is not just with NHFT. We've also got to rely on our local authority partners. There's a police interface, etc. In terms of Note to 19 contract, I think it's early days to fully establish whether the model is the right one. I think we should be in a position going into 26, 27 to be able to describe whether we need something different to be able to drive the outcomes that we want. And we would expect to see that with such a new contract and a reduction in the resources. The contract envelope obviously decreased, and we've had to mobilise in that context. So we need to understand what that looks like once we get over quarter two, and I'd expect to be able to kind of provide a bit more clarity on the trajectory of those services in quarter four of next year.
Thank you, Councillor Geary. Anything else? Any follow-up questions? No? Members, any questions? Councillor Harrison.
Thank you, David. It's really good to hear, that these services are rated so highly, and that's something that you guys should be really proud of, because it's, you're under so much pressure, and it's very difficult at the moment to deliver services of a high quality, given all the demand-led pressures that I'm sure you're dealing with. And one of the things that we're always hearing about, particularly since COVID, is the increase in pressure on mental health services in particular. So I was sort of interested in hearing a bit more about the sort of strategic plan that you have, probably with partners, to improve access to CAMS and adult psychological services, because I'm sure that you do have waiting lists, and there are pressures of those sorts. It's something that people often talk to us about. They can't get access to services, or it takes such a long time. So I just wondered if you could give us a bit more information about that.
Great, thanks, Councillor Harrison. So nationally, I think we saw post-COVID quite a significant increase in demand for child and adolescent mental health services. Hopefully, King's College, there was a significant driver in that around neurodiversity and neurodivergent needs. We have had what I think now is a bit of clarity emerging from some research on ADHD and the increased prevalence that we're seeing in neurodiverse conditions. And that seems to be driven less about a new COVID-driven demand, but a greater understanding at community levels of identifying that need, which hitherto had been not identified, and also a reduction in stigma, so people feeling better able to articulate the needs that they have. So as a provider, as a mental health provider, we welcome that. We welcome the clarity that this is not a new trend. We're not seeing increased prevalence levels. The prevalence was there before. it is now more visible, and there is less stigma from people being able to articulate the needs that they have. What hasn't kept pace, of course, is then necessarily the resources required to be able to meet that demand. And that's where we find ourselves. We do not have all the resources that might be required. Nobody does. That's the nature of trying to operate in constrained public services. But we are trying to use the resources that we've got for best effect, which brings us back to the partnerships bit, it brings us back to the voluntary sector, it brings us back to our work in schools being foundational. Helpfully today, national policy illustrates that suicide prevention will form part of the education curriculum from next year. That's new. That's maybe 20 years in campaigning for that to happen. So these are not things we can solve on our own. It's got to be a confluence of curriculum support in education. We now have more resources going into mental health in schools. That is an ambition of this government. We're meeting that ambition locally, and again, we're seeing the impact of that. It's not enough for your constituents, I recognise that, but we are going as fast and as further as we can. But I do feel that clarity from King's College does give us now some clear blue light to be able to navigate some of the complexity that we find post-COVID.
Thanks. That's really interesting to hear that it's not new demand. It's just previously undiscovered demand. So that's I guess reassuring in some ways that you know people aren't getting sicker than they were before. So I'm just thinking about the stresses and strains and the demand and as you say, you know, we know that there isn't enough provision and you can't just magic it out of thin air. Do you do any sort of this might not be you, it might be public health more, but do we do any work with communities in helping local communities to be able to pick up early when people are struggling and to be able to ask the right questions? Because often it's about asking the right questions when somebody's you know, having mental health difficulties, and members of the public often find it very difficult to ask those right questions. And I just wonder if we do any work with our communities to try to help with that type of early help, you know, prevention and early intervention work.
If I may, Chair, I'll ask Shirley to...
Yeah, go ahead. Go ahead.
Thank you.
Thank you, Chair. So there's a couple of strands of work that public health supports. Some of it is through the local area partnerships, and again, through the health and wellbeing strategy, mental health is one of our priorities, and that's a system-wide priority. Obviously, from a public health perspective, that's very, very early intervention and prevention activity, and there is work ongoing at the moment looking at what our model and what our spend is going to look like in the future. Some of the activities that we do undertake is providing resources to schools. There's a programme, it's called Bounce Forward. It's a resilience programme for parents and children. So it supports families to consider the mental health and that low-level mental resilience that we want to grow in our young people. There's also a lot of discussions at local area partnerships about what mental health support, mental health and wellbeing would look like, and obviously public health will support that. And there is the health inequalities additional allocation funding that we hold on behalf of the ICB is a pot of money where local organisations can bid into through that LAP structure to deliver exactly that. So there's a range of activities, and I think another project that public health have funded, both public health funding and the HIAA funding, is trauma-informed practice. So that's training colleagues across the system to recognise that trauma and take a trauma-informed approach. And part of the legacy of that project is a train-the-trainer model, so that it helps support those activities just across the system, and we get that better ability to talk to people as professionals, but also to support the VCSE to roll that out through their networks. So a range of activities, and definitely more in the pipeline.
Brilliant, thank you.
Any questions from the members? Councillor McLean.
Thank you, Chair. Councillor Harrison has made some good points there, and I think I'm one of the only people here who's old enough to remember the days when we had hospitals where people were basically locked away and forgotten about. I was a young student nurse, psychiatric nurse back in 1066, and sorry, wrong date, and worked in these places where basically people were locked away. And over the generations, people felt that this was something we had to keep quiet, and it wasn't manly, you know, in that word, to sort of say you've got problems. But now I feel that in the sort of modern day, there is the people are coming forward to say how they feel. One of the things that I've been looking at here is that is there any area that the CQC or NHS England are looking at the situation, maybe to see that everything is being correctly carried out, or there's problems in the area?
If I could ask you, Councillor, could you just go a little bit further with the question, just clarify, just reframe it.
Basically, it's about was there any areas that are of the operations that are currently under enhanced monitoring by CQC and NHS England?
Thanks, Councillor. I understand the question. We provide, there are no current areas in Northamptonshire in relation to service provision that are under regulatory scrutiny. We do have secured services provision in Bedford that's been undergoing quite a significant range of challenges. We do have some improvement expectations from the regulator in those services, but none in Northants.
Thank you. I think David wants to say something.
Sorry, Dave, go ahead.
Thank you, Chair. My finger wasn't waving enough, obviously. I just wanted to, really interesting questions, and I wanted to just bring in, from a local authority, a lot of the activity that we also do, as well as alongside public health. And I've just given Shirley a nudge because there's one thing which I know that she should have picked up on, so I'll ask her to come in after me. But there's lots of work that goes on in just some of our mainstream functions within the council, so within our libraries, within our leisure centres that really help contribute to some of the health demand that we have across Northamptonshire. So, for example, in Lodge Park Leisure Centre, we have some particular cardio rehab sessions which are run by our leisure assistants. That reduces demand on both our acute hospital but also on our community services as well. And even within our public, within our country parks, there's well-being functions and activities happening. So I'll bring Shirley in at that point because she's far more of a guru on this than me.
Thank you for the prompt, David. So yes, I can't believe I forgot this because we in Public Health have been working with our colleagues in Place and Economy to look at projects, one in particular called Active Parks. So it's a combination of sessions. It's encouraging people to use the outdoors for their mental well-being. We funded a VR headsets and filming so that people are not comfortable coming out to parks initially. They can be gently moved through those processes of understanding the benefits until eventually they are happy to come and experience the country parks. And as David said, there are many other activities through the work we do with leisure colleagues. So, for example, wellbeing walks, again, where people have anxiety or are suffering from social isolation, they can be enticed into a safe space with like-minded people for wellbeing walks. And those are self-sustaining groups. And what we often find in the feedback we have from our leisure colleagues are someone joins, they enjoy it, they actually get trained up as a walk leader. So this network of walks is across Northamptonshire area, and we support that to keep it growing. So there are a number of projects and other projects which ostensibly are around food, but it's around growing and cooking. So again, it's getting people out in the fresh air. That's delivered through groundwork. So we've got a range of projects that are more at that well-being end of the spectrum, if you like, which the aim is to reduce the impact and reduce crisis incidences. And we see some real successes, and I think our colleagues in leisure really do a fantastic job at delivering those. And again, the Active Parks project, which I can't believe I forgot.
Thank you, Shirley. Any more questions from the members? Councillor McLean? We'll just do one or two more questions. Okay,
just one.
I can see
just
Laura's
one.
itching.
Coming back on the getting people out or getting them to sort of exercise and get in the gym, I think the health board, they were talking about in Northamptonshire putting exercise equipment in parks, and it was mostly things like, sort of where people can do a bit of exercise, but I was looking at the plans for it and I don't really think it's the right type of equipment. I go to the gym 3 times a week and I've always did that weight-bearing exercises, but the stuff they want to put out there, you'd have to be pretty professional to use it. But there's other equipment that can be put there which would be suitable for that sort of thing, and it would save people having to have gym sort of fees and stuff like that. That's all I know.
I mean, to support the conversation, there's a good piece of research done by a guy called Vikram Patel in a social enterprise in Southeast Asia, and it's called Where There's No Psychiatrist. The Sangath was a social enterprise. But the model they used was exactly as Shirley described, where we upskill, and Councillor Harrison's point about families and upskilling individuals to be able to support family members with mental health needs, doing that work in a focused way, allied with resources that Shirley described, had a profound impact on mental health need and almost mirrored the effectiveness of Western psychiatry. So that model of public mental health that we've just had a brief conversation about is pretty foundational to managing demand and need where we find it, so more of it.
Thank you, David. I'm going to wrap up the questions there because we've still got a couple of agenda items to get through. So thank you, David, and for everybody else who's chipped in to answer the questions. We've got a few proposed holding recommendations, which I'll read out. There's 3. The first one is mental health transformation oversight. It's recommended that NHFT returns to the committee with a detailed update on the impact of community health transformation, including access, outcomes, and workforce capacity across Northamptonshire. I can see you writing these down. We'll send them out to you afterwards. We've got CAMS and CYP mental health access monitoring. So it's recommended ongoing scrutiny of access to children and young people's mental health services, with particular attention to waiting times, early intervention provision, and the impact of inpatient and outreach models. And then finally, inpatient quality and safety reporting. It's recommended that NHFD provides the committee with regular assurance on the safety, staffing, and outcomes within its inpatient mental health facilities, particularly those flagged nationally as higher risk service areas. Thank you, Raj.
Chair, if I may, I don't know, procedurally, I guess we'd probably need to just understand kind of the level of detail this committee might ordinarily receive in terms of its oversight function. I mean, defer to Raj on that point, but there's quite a lot of detail there that is covered in public board reports through the trust board already. So just being clear about what exactly we're providing here in terms of our...
Yeah, so the information requested may be delivered in the form of a briefing note that we can circulate with committee members in a few months' time. It's not for current right now, but we'll forward you the recommendations if you can provide some information in writing, or when you come back and attend a future meeting, we can table those discussions for the meeting itself. David,
do you want to chip in first?
Yeah, so certainly all 3 organisations produce annual reports, which will contain a lot of the information which are being requested and links to probably governance papers. So I think how we've tended to manage it in previous health scrutinies is that each of the respective organisations would bring and present their annual report, and then if there were areas which were flagged as a result of that, that we would then put them on the forward plan at that point, because otherwise it's asking all the organisations to reproduce in a different format a lot of the information which is covered in those annual reports. So if I could propose that that's the way that we manage it, that we do it through the usual reporting cycle of each of the boards, and then on discussion of those we can then determine, is there 2-3 items that Scrutiny wants to pick up because they're being highlighted as issues or outliers from a national performance perspective.
Yep, we'll take that recommendation, David. Thank you. Okay, on to the second to last agenda item, number 7. We have Kettering General Hospital introduction with Laura Churchwood. Laura, thank you so much for your patience this evening. Over to yourself.
Absolutely no problem with the patients. It's been really interesting to hear what others are doing in the system, so thank you. I'm really conscious of time, so I'm going to try and do a whistle-stop tour. I'm responsible for Kettering and Northampton Hospital. If we can go to the next slide, please. And Robin is here as the Director of Nursing specifically for Kettering. What we're going to do is I'm going to cover 4 slides with just an overview of where we're at with Kettering and Northampton, and then Robin's going to do a bit of a deeper dive into 3 of the areas of concern. I've noted some of the regulatory questions that we've had, and we've tried to focus on those areas where we have had worries in the past. Probably should admit that I'm relatively new in post, so I've been the Chief Executive at UHN for 9 months, and Robin's 4 weeks ahead of me?
Yes, 10 months.
10 months. But we've done a lot of work in those 10 months, still lots to do, and we're really happy to come to Health Scrutiny to get views from councillors. I would also echo what Dave said in his presentation, really happy to open our doors to councillors to come and have a look around Kettering or Northampton General. We will always welcome you, and we always welcome visits and scrutiny from the outside, including our patients. So, just in terms of the 2 front doors that you can see there, Kettering is the older of our 2 sites, and it's probably the one that I've got the most worries about in terms of the estate. So when we go on to the next bit of the slides, I'll just talk you through some of the issues that we've got there. But you can see the 2 front doors. We work across the county. One of the things that has really improved since we started working across Northampton and Kettering is access. So we've transferred 1,000 patients. That was probably about 2 weeks ago. We met our 1,000th patient between the 2 sites to sort of equalise the waiting list, because if you've got lots of patients waiting a really long time in Kettering and you've got a shorter waiting time in Northampton, we need to try and equalise as much as we possibly can. And also, like Dave said, we've got some shortages of medical staff. Like the rest of the country, actually we need to work in a collaborative way. If we can go to the next slide. So these are some of the things that we're trying to focus on. I'm going to point you in the direction of the picture. So this picture is Kettering General as it should look when we get the rebuild. And I've put this slide on deliberately because it's one of the things that I'm most passionate about. I think Kettering General, the estate is old. It does need replacement. We are in the process of delivering that. So one of the points I'll come on to is we're just about to kind of dig in the ground for our energy centre, which is the first block before we meet the needs of the new hospital. But I think the new hospital probably won't be in situ until the 2030s. However, it's really clear to me that we do need some new facilities at Kettering. There are some bits of the estate, if any of you want to come round, that are newer and in much better shape, but the big block is in need of what I would sort of say desperate rescue, because it is an older block and has lots of issues. So in terms of what we've been trying to do, we're obviously trying to meet the aims of the NHS as a whole, but the things I'm most happy with is our elective care times, as Toby has already articulated, are good in the county. They're not 100%, but they are better than most counties. There's always things that we can do to improve this. We try as much as we possibly can to see patients wherever we can, and we do use some of the private sector work that Toby has outlined in order to do that. And we're trying as much as we possibly can to make care local to patients, and I'll come on to that in a second. The other thing that's really critical is improving urgent care access. So urgent care is care that's accessed through the emergency departments, essentially. I'm going to be honest, we've had lots of issues with this. All hospitals have lots of issues with this. Just to give you a sort of view of the volume, about 900-ish patients a day come through the EDs across both hospitals. So about 450 in Kettering and about 450 to 500 in Northampton. These are big numbers, and the A&Es were never built to cope with that number of patients going through them. So we have had to adapt the way that we care for patients, and it is difficult, particularly in winter. But we're working really hard to try and reduce our department waiting times, and we've had real success in Kettering particularly. It's a bit more of a sticky issue in Northampton, but in Kettering we have really reduced the amount of times that ambulance wait to offload, and we have really tried to work hard on reducing the number of patients waiting over 12 hours, because it's the patients who wait overnight to get a bed that worry me, and those are the ones that we need to try and focus our attention on. We're also well provided, actually, in the north of the county with urgent and emergency care facilities that are not A&E. So the urgent and emergency care centre in Corby, that's not run by us but sees a lot of patients, that does really help in the north of the county. We don't have the same provision in what I would call the south, but it's actually the west. So that provision is really good in the north. And we also work with your colleagues and also colleagues in the west to support timely discharge away from hospital, because a lot of patients that come into hospital, they need care afterwards. They've had a fall, they've had a respiratory illness, sometimes they cannot go back to their place of residence, and we need to provide additional care. That can be tricky. We need to be, again, honest about that. And the other thing that Robin will touch on a little bit in a second is some of the patient and colleague voice that we're trying to do. I think one of the jobs that we've got to do as a leadership team across Kettering and Northamptonshire is properly listen to patients when they tell us we've got it wrong. That's really important. Sometimes we won't be able to always get it right, but actually it's a really fundamental thing that we've tried to develop over the last few months, and Robin will go into a bit more detail about some of the work that we've done, particularly in children and young people's services at Kettering. And the final thing on the list is probably the thing that worries me. Well, it's not the thing that worries me the most, but it's one of the things that takes up the most time, which is the finances of the NHS. We're not alone in this, but the acute hospitals in the county are a huge amount of the deficit problem. We have done a lot of work in reducing that deficit, but there is still a long way to go. And this is all really difficult stuff to do at a time where you've got to improve services to patients and improve the culture of the organisation as well. If we can go to the next slide, please. So just to think about some of the innovative stuff we're doing in Kettering, and I wanted to highlight specifically some of the Kettering stuff. So robotic surgery, there wasn't a robotic surgery programme at Kettering, there still isn't, but by the end of the month there will be. So we had a robot that was at Northampton, and one of my first acts as chief executive was to say, actually, we need to equalise the provision across the county, so that now we've got robotic surgery for both patients in the north of the county and the south of the county as well. I think it's really important that we have equal access, and it also means it's kind of easier for us actually to plan, because robotic surgery is quite sort of resource intensive, and it's a really good thing to sort of teach on as well, so we can get more juniors into Kettering, we get more consultant appointments into Kettering, so we're really trying to equalise that opportunity. The other thing I would just point out is we've just put in our electronic patient record at Northampton, which is called Nerve Centre. Kettering does already have a system, but I think we do need to look at it because it's quite old. So there is quite a big amount of work that we've got, or quite a large amount of work that we've got to do in terms of digital enablement and the use of AI for things like clinics. So, for instance, you can have AI in a clinic room that will take the notes between a patient and a doctor and basically transcribe them, which obviously is better from a quality perspective. We've got lots of people who've been on the pilots for these services and love them, but it also may save us a bit of money as well. If we can go to the next slide, please. And this is the final one from me, which is investing in estates. I've just just put a plug in for the new hospital at Kettering. The picture in the background here is the Corby Diagnostic Centre, which literally just opened. It's worth going to see. It's lovely. It even has parking, which I'm thrilled about. Not sure it's enough, but it has got parking. This is a really fantastic facility, and I noted what the councillor said in terms of cancer rates potentially in Corby. This is a facility that will offer patients in Corby faster access to diagnostics. So there's ultrasound, there's CT there, there's echo, there's a range of diagnostic facilities, which is often one of the things that underserved communities have problems accessing. And it's one of the things that we need to do kind of as close to a patient seeing their GP as possible, rather than wait to see a specialist. So I'm really pleased that this is a new community diagnostic centre. We've also got one in Northampton, and there's a potential that we may open a third at some point, but the one in Corby has just opened. We're also planning to do some work on Rockingham Wing. For those of you who don't know what Rockingham Wing is, it's where maternity is and the neonatal unit as well. It's got RAC. It's been very difficult to manage as a hospital site. These are not easy situations to find yourself in, and we've got quite a few temporary buildings. We're in the stage of getting planning for basically the back end of Rockingham Wing to be expanded, so that'll be a new neonatal unit, and we've only just opened a new unit, which Robin I've probably stolen your thunder, haven't I? We've just opened a new maternity unit in Rockingham, which has been fully reinforced, and it's a lovely facility for patients. We've also kept the temporary facility that was open for maternity for extra beds for elderly care and our discharge lounge. Finally, on this slide, the energy centre and car park. You may think, why is she mentioning the car park? We've got to move car parks around the site. If any of you have ever been to Kettering, you will understand it's really landlocked, same as Northampton. So we have to essentially move car parks in order to fit in the new building. And our energy centre is just about to, well, they've started the work, but essentially you'll start to see stuff coming out of the ground relatively soon. Again, my old job was building hospitals, and one of the things you can't get wrong is energy. You have to sometimes build new substations and stuff to meet the power requirements, so this is part of that plan. And the final one on this list is the mortuary. We're working with West Northampton Council, but also Northamptonshire Council to improve mortuary facilities. So it will mean that the mortuary at Kettering will close, but the new facility will be just at the Riverside Hub. I think it's going to be a fantastic facility. We don't offer viewing at the moment for relatives, and this new facility will offer bespoke viewing for relatives. So I think it's a really positive step forward. And that facility will open in probably November. So I'm going to just hand over to Robin quickly to cover the three areas that we were most concerned about at Kettering, and just talk little bit about the improvements that we've made.
Thank you, Laura. So children and young people services, so we're committed to improve the services across our children and young people pathway. As such, we are committed to 7 pieces of work to improve that service. So I'll just draw out 3 of those if that's okay, but there is a golden thread within each of them that will improve that service. So the first one is the leadership and the culture. So we've recruited to key leadership roles, and we are supporting them to do the best job possible. That in turn will improve the culture within that area, and we are already seeing benefits and the impact of that with a significant positive reduction in our vacancies and creating a better environment for our colleagues to work and work within. And as such, we have seen a 35% reduction in our dependency on temporary staffing, and we'll see further reductions as we move through the year, which is really, really positive. We're keen to work with our families, so it's great to improve the environment that our colleagues work within, but actually the key service user here is the children, young people and the families. So what we are doing is undertaking listening events, so we're committed to listen, learn and improve the services we are delivering, and as such during the month of June and July we held a series of listening events which were quite difficult to walk into initially because of a lot of these families we didn't get it right for, but actually it was a really positive experience to listen to what their experience had been and actually what do we need to do as part of our improvement journey to get it right for the future, recognising we didn't get it right for them, but we are committed to get it right for future people, and we are going to carry on with that piece of work. The other element that we are doing is effectively planning for winter. We know winter is around the corner, and we do know we see seasonal variation in children attendances, and what we do recognise from some of our instances, we didn't get it right at that component, so the work that we are doing will help at the front door and as you move through the pathway to ensure that children and young people receive the best care possible, and we're supporting our colleagues within that. That in turn will feed into learning from our incidences, and this collective piece of improvement work is feeding into a quarterly meeting which has attendance from ICB colleagues, NHS England and the CQC, so they are keeping track of the improvements that we are making, but also as well we are committed internally to make those changes that are needed. And walk around today speaking to the team, they do feel it on the ground and actually go, I do feel now I can speak up, which is really, really positive. Moving into the next one. So as you will see, we're part of the National Maternity Safety Support Programme, otherwise known as MSSP, which is a little bit shorter but often difficult to remember. So this is a national offer to improve the maternity services that we do deliver at Kettering General Hospital. A lot of the recommendations came from that was stuff that we'd already had in plan as part of our CQC work, which one was positive, we were focusing on the right things, but also enabled us to obtain support from regional colleagues, but also national colleagues. So we're getting support from a obstetrician and a midwife who've worked in similar sites who are encountering some of the same challenges and issues that we are, which is positive. Some of the feedback from them that we've received is our team is engaged, a commitment to improve, because overall we want, again, similar to children and young people, we are committed to improve that service, that people who are choosing to attend KGH, women who are choosing to have their baby there, have the best care possible. As Laura already stole my thunder, we've already made some work in our Rockingham wing, and we've opened a new ward within there. That was closed due to RAC, that's now been stabilised, but also as well what it has offered us is the opportunity with that new estate, that increased footprint, to actually allow birthing partners to stay overnight. So when women have babies, their loved one who is with them during that special moment can stay with them overnight. The feedback's been really positive, and it was recently covered by the BBC News around actually how we're doing that, which is really nice because actually it's a special time, so it enables people to do that. There's further work we are doing around improving our digital enablers, and by the end of September we'll have Badgernet in place, which will enable our colleagues working within the community, colleagues working within the hospital to share records, so that will enable that beginning to end patient experience. And also as well our continuous commitment to improve, we're also identified that we need to increase our workforce. Our workforce is fit for now, but actually what we are doing is planning, and by that we're recruiting 10 additional midwives and working with the university on how we can recruit those colleagues into those key positions, which is really important. But also as well, we are also listening to families accessing those services to go, actually, the changes we're making, are they right? As we established from the BBC, it was positive, the ability to stay overnight, but also what else can we do? And as we move into the new build, what can we do then as well? The next part is around neonatal unit. So back in 2023, the neonatal unit was downgraded to a level 1 unit. So that basically means it's special. Sorry. So that means that babies who are level 1 is special care babies, so they're not level 2 who require an additional level of support, or level 3 who need intubating and put into sleep. So we've done a lot of work over the last 2 years, and I can only talk about the 10 months that I've been within the organisation, but in November we went back to a step-up unit, and then back in May 2025 we're then able to take level 2 babies as well. So previously these babies were going out of area, so that may be to Northampton, that may be to Leicester, and our ability now to take multiple births as well is really important, because what we do know is for some parents, if they're having a multiple birth and they need a neonatal unit, they may get split up. What this now means that we're able to keep those babies with us if they meet the requirements, but also as well offer support to Leicester and Northampton, so we're keeping those babies within the area. It's been really positive. The feedback from families has been really positive. Patients who previously been who have had to be transferred out to other units, because when we switched it back on, they came back, they were very, very relieved. other families who've accessed our services who, through friends, through networks, had heard that their babies had gone out the area, they'd actually been able to stay in Kettering. So that was really positive. So when we've been visiting the families, speaking to the families and hearing that feedback, it's really positive. But our key priority is to maintain our focus on the safety. It was downgraded for a reason, but so our continuous oversight, and that's where it's then feeding in our quarterly review, which is attended by the ICB, NHSE and the CQC to actually go, these are the improvements that we continue to make. So our firm belief is that we are on a continuous journey and we'll always continue to improve. And by listening to the families, look at how we need to improve, and as we move into the new build that Laura's made reference to, they're going to be key in what that looks like, how is it designed, and what does that mean for them as well. So we're almost doing it in partnership. So I'll stop there, as I can quite happily talk about this quite extensively, because it's been an important piece of work for us to do, but it's an essential piece of work. And for me, personally, as the Director of Nursing for KGH, it's that continuous listening, improving and responding to our patients is important. Thank you.
Thank you, Robin and Laura. Before we get on to any questioning, I just want to check it's 9 p.m. Is everybody still happy to continue? Yeah, all right, we'll crack on. I'll start with this side of the room because I feel like I've been... Councillor Geary.
Thank you, Councillor Gibbs. You spoke about the recovery of elective recovery efforts and that your performance was good. What does good mean?
It means we're in line with the national standards, but I guess we could have a debate about whether the national standards are where they need to be. So we can share our elective percentage rates with the Health and Scrutiny Committee. I don't know them off the top of my head because there's about 30, but I'm really happy to share those with council members if that would be something that you'd be interested to see. Broadly speaking, we're in line with the national expectations in relation to both cancer waiting times and 52 weeks. Now, I remember I've been in the health service for 25 years. I remember a time where our waiting times were less long than they are at the moment. So my view is that we do need to do further work to improve them. I would absolutely like to see waiting times fall for patients. But we have to acknowledge that we're in a time of constraint and we have got overwhelming need across the hospitals. If you think about the sort of split between electives, which is planned surgery, and non-electives, which is patients coming through our emergency access pathway, it might not always be through ED, but it predominantly is. The split in terms of bed numbers is about 85% patients are in the emergency pathway and 15% are in the elective pathway. It's heavily weighted to patients who are very unwell and coming in from home, the bed base.
Is that because the hospital was designed with that percentage split originally? Was it designed for that kind of split?
No, I don't think so, no.
Okay. Corby Diagnostic Centre, we spoke of that being open. Is it able to handle the capacity, the demand that it's getting?
Yeah, so it's currently in its kind of opening phases, which is like a staggered demand. But yes, it will be able to handle the demand that it is designed to take. We've staffed it appropriately, and we're doing some collaborations with private providers where it's more difficult for the NHS to staff services. I'm not worried about capacity at Corby, and I think it will be a really fantastic facility for patients. Part of my job is to make sure that we've got the relevant staff to staff the areas that we're going to open. But no, I'm not worried about that. And currently we're at a reduced demand as we sort of ramp up the facility because it only opened about 2 weeks ago.
And last question is about technology. We speak about robotic surgery, talk about AI.
Yeah.
But earlier on you also spoke about the need to listen because we're dealing with people. How are you dealing with those potentially two divergent methods of dealing with health?
That's a great question. So the robot isn't designed to be used without humans, and neither's AI, in my view. I mean, I could probably do a lecture on AI and my thoughts. I think AI is there to complement. It's not there to do medicine yet. It might be in 10 to 15 years, but at the moment it's not. And the robot is designed to be used by very experienced surgeons in order to make surgery more precise, and it's used in a very sort of limited subset of surgery. The AI that I talked about, so ambient AI, which you might use in a clinic setting, doesn't replace the doctor. It's there to help the doctor make accurate notes of a conversation with a patient in a way that is much more streamlined.
Just got one last question, if I may. On the question of patients and people and technology, is it fair to say that careers are enhanced by promoting technologies, but may not necessarily be enhanced by listening to patients?
Oh, I don't think I... What do you mean by that?
People want to be cared for, and quite often it's difficult sometimes to define that. Whilst if I'm on the project that delivers a new shiny box, for want of an expression, that's a way of gaining recognition in your career.
Oh, okay. I'd never thought of it like that. I'm hoping that during the presentation you got the strong sense that Robin and I really want to listen to patients and we really want to listen to staff. This isn't about, for me, it's never been about new, shiny technology, except for where it's going to improve services to patients. So robotics, for instance, you get much better outcomes. We've just implemented something called HIFU for prostate cancer, for instance. New technology, but it's much more precise. And it's much better in terms of outcomes. I think any technology in health and any other specialty, you have to evaluate its need and you have to make sure that the outcomes are better. For me, it's never about introducing the next new shiny thing. It absolutely is understanding what patients want and what our staff are telling us as well.
Thank you.
Thank you, Councillor Geary. Councillor Lumsden, do you have some questions?
Thank you for that presentation, and thank you over the other side as well. I'm quite passionate about health. I have to commend Councillor Pengelly earlier for his passion. I'm actually one of the stats he was talking about in Corby regarding lung cancer. So I do have I'm quite passionate about that. Getting back to the questions, can the committee receive progress reports on the Children and Young People's Services Improvement Plan, especially around triage, assessment and family engagement?
Yeah, so hopefully you've got some of the... Oh, sorry, there's an echo. Hopefully you've got some of the feedback from the family engagement from Robin's presentation today, but I'm absolutely happy to share with committee through Raj the papers that have already been through our public board, which have the progress that we've made against some of the improvements, and also gives you a full outline of our family engagement, which I think you can probably tell Robin's really passionate about it, but it's like a key fundamental. We need to listen to communities. We need to listen where we've got it wrong, and we need to put it right where we can. But yes, absolutely happy to do that, no problem.
Thank you. And also, what further scrutiny may be needed around the implementation and performance of the new electronic patient record, the EPR system? Particularly with respect to data sharing and continuity of care?
That's a great question. So we don't currently have... I'm really sorry, there's like an echo. Do you want to turn your mic off and see if it helps? Yeah, it's going to. It's me. I'm keeping my mic on too long. Too keen. So we don't have an electronic record across Kettering and Northampton yet, but if you wanted to ask my aspiration, it is to have the same record across Kettering and Northampton. I think that would make a huge impact to how we can data share across the two units. Again, I will go back to like previous times where I've been an ops manager years and years ago, where we'd like send CDs, recorded mail and all that sort of stuff. We're not in that place anymore, but there is lots of things we could do to improve the sharing of information. One of the things that we have to be really cognizant of with any electronic system, and most most services, including local councils, they're all very reliant on electronics. Is one, you've got to have a backup plan if it all goes wrong, i.e., generator fails or whatever. And two, you've also got to be really cognizant of the risks around cybersecurity and keeping patients' data safe. And that's absolutely something that we would monitor through our board to make sure that we're cognizant of the risks. But to be honest, newer systems are normally, I would say almost 100% better than older systems. Where you have to worry is where you've got older systems that are sort of 15 years out of date. That is normally the sort of more risky time. So I think moving to newer systems is normally the way that you would make data much more secure.
So you're saying there's no system for test results?
No, there is a system. It's just what you have to do with Kettering and Northampton is if you're in Northampton, you have to log into the Kettering system, and if you're in Kettering, you log into the Northampton system. So there is a system, but it's not it's not what I would call a traditionally shared system across the two sites. I would say the two hospitals are on the they're not as digitally mature as some of the other hospital sites within the country, but I think we've got a plan to get them to the place where they need to be over the next 5 years.
I think all the other questions I had have really been answered by Robin.
Okay, thank you. Councillor Lumsden, this side of the room. Councillor Harrison.
Thank you. Thank you so much for your presentation. And yes, your passion, both of you, really shone through. So thank you for that. I want to just reflect on one of the questions that Councillor Geary asked you, and then just ask another different question, if I may. So he was asking that question about sort of the dynamic between using new technologies, AI, and the possibility of an impact on patient care. And I think it's about choosing the right kind of technology, because if you do, you actually free a clinician up to probably be able to do more in terms of patient care. And that's where the balance lies, doesn't it? It's in making sure you've got the right solutions, so that actually as a clinician you can go out there and you can spend more time with your patient. I mean, I can just imagine if you've got AI writing all your notes for you, you haven't got to sit there tapping away on a computer where you've got a screen between you and your patient, and those kinds of things must make an impact, a beneficial impact on patient care. So it's just a reflection, really. But then the other thing, you were talking about technology and data and protecting data, and I'm sure you must do. But do you have plans in place for the terrible event of a cyber attack or anything like that? Because that's a pretty serious and has caused terrible problems in other health systems.
Yes, so we had I think it was at board, but it may have been at a different committee, but we have had an in-depth conversation about cybersecurity. It was at board, I've remembered. I think it was at private board. We had an in-depth conversation about cybersecurity in the last 6 weeks. We're very conscious of what has happened to other health systems. I think what I would say here is you can never say never. What just happened to Marks and Spencer's just sort of proves that actually you can have really robust technology and still be at threat. But again, it's about having backup systems if something did go wrong, and making sure that you're looking at all your fragile systems, because hospitals and all health providers run on multitudes of systems everywhere. So it's about having expertise within the system, and we have a cybersecurity expert who works cross-system, who does a really fantastic job of advising us where we might have issues or concerns, and where we don't have issues or concerns as well. So yes, it absolutely is something that we keep on the agenda. I don't know whether any other colleagues want to come in.
If I may, Chair.
Yeah, we'll go to Janine and then David Watts afterwards, yeah.
We have recently had a combined system event looking at how we would cope with a cyber incident with colleagues from UHN, UHL, NHFT and LPT, and our shared cyber expert, as well as some very insightful presentations from large banks who've been hit by cyber attacks, in order that we're forming our emergency preparedness for a cyber attack across the system, and that includes all of us in case that were to happen. So that's work that's in train. We've had a very interesting morning where we worked through all the things that would happen, inclusive lots of technological advice from the technologists that work with us, and also that national and NHS England support as well. So we're working through that, and actually we'll have some very robust plans, I think, in place if that were to happen, but also that education piece across all the staff that work in our IT departments and our emergency resilience departments across all organisations, so that if we were to unfortunately be struck by a cyber attack, that everybody knows how to manage that so that the damage is limited when it occurs.
Thank you, Chair. Trust there to be a geek in the room. So I'm the Council's Caldecott Guardian, and each of us as organisations will have information governance boards as well. We're all expected to complete data security and protection toolkits on an annual basis, which is a self-assessment of the organisation's capacity to manage threats against its data. So there's lots of rigour in the background around that. I think, can you completely eliminate those risks? I think there's been plenty of instances where we've seen that you can't, but it's about, do you have the contingency plans to manage in the event of that, which certainly within the local authority, we have a lot of discipline and organisation that goes into managing those sorts of things. And particularly when we're talking about things like integrated care records as well, which is an ambition for us as a system, that our health and social care systems can talk to each other. There will be requirements that we meet those sorts of standards, and that is shared across the whole system as well.
Thank you for those responses. Councillor Harrison, anything else you wanted to add to that?
No, thank you. That's really reassuring. I expected that that would be the answer, but it's good to know that there are robust plans in place for if backup plans for if there was a cyber attack. I have a friend who is a physiotherapist in Ireland, and their hospital suffered a cyber attack, and they were, I think, because I think I'm right, they wouldn't pay the ransom to get the systems back up and running, and they were without their systems for about 2 weeks, and yeah, they had to go back to paper and all sorts. So yeah, it's good to know that there are plans afoot for should something so terrible happen.
Thank you, Councillor Harrison. I just want to make sure everybody gets an opportunity to speak, so I'll just check. Councillor McLean, any questions?
No, I'm fine, thank you.
Councillor Howes?
Yeah, yeah, I do actually. It was asked at the very start of the meeting about potential strikes, and I'd just be interested to know what contingency plans are in place for such an event.
Thank you. So the strikes are planned for next week. We are in the current process for planning the contingency and essentially enabling consultants and other specialists to act in the place of our resident colleagues. This is always difficult to plan for, but we have done it several times in the past, so there is a sort of robust way that we do this within both Northampton and Kettering. And we try and agree rates for those sessions across a wider footprint than just Northamptonshire. So we're trying to manage equity and fairness across the patch. What we'll do is essentially from probably tomorrow onwards, we'll have daily huddles where we look at what the issue. Well, they're already having daily huddles actually to look at where we're at, what shifts we've not got covered, what we need to do. potentially what you would also do is you will down some activity. So you may not do the elective surgery that you had planned to do. You may stand down outpatient clinics in order to release consultants to do kind of direct line care for urgent and emergency. And we will also make sure that we try and tell the public not to attend hospital unless absolutely necessary. I think that's a really important message during strike action. Because I think we need to try and reduce demand as well as cover the shifts, because it is a significant proportion of the workforce that will not be available to us for a significant period of time. It's quite a long period of strike action. I think my personal view is the strikes will go ahead, but I've got no evidence to the contrary, and we have to plan as if they are going ahead, because that's what we have been told.
All done, Councillor Howes? Thank you. All right, we have some proposed holding recommendations now. 3, Children and Young People's Service Improvement Oversight. So it's recommended that the UHN provides an update to the committee in 6 months on progress against its 7-point improvement plan for children's services, with a specific focus on triage, family engagement and workforce development. Number 2, maternity and neonatal assurance. Recommended that the committee receives a further update on the implementation of the Maternity Safety Support Programme and progress against KGH's maternity and neonatal improvement actions, including estate developments and staffing plans. And then the third and final one, digital transformation monitoring. Recommended that the UHN submits a future report on the impact of the electronic patient record rollout across Northamptonshire, highlighting data sharing improvements, clinical safety benefits, and areas requiring further investment. Thank you. Which takes us to the final point on the agenda, number 8, the health scrutiny work plan with Raj.
Yep, thank you, Chair. So looking at the work plan, we have quite a comprehensive list of standing items that will come later in the year and early next year. Some of these things include the NHFT annual quality report. We've got some internal reports such as the Director of Public Health's annual report, and ongoing work such as the Orchard Project around dementia research, health protection on winter preparedness and substance misuse. So it's quite a big list we have as it is. I've also added on the items to be scheduled around the cancer rates that Councillor Pengelly mentioned earlier. As always, if members have anything they would like the committee to consider, that can be submitted to the Scrutiny Management Board for consideration, which will then be added to the work plan. And also, as always, with the Scrutiny Management Board, any items going to the exec that we deem appropriate to be considered by health scrutiny will be added to the work plan. Thank you.
Councillor Harrison, go ahead.
Yeah, thank you. So just my reflections on the exercise we've just gone through today. It's been incredibly broad in scope. It's really, really interesting, and it's brilliant to have had you here. And obviously, we wanted a bit of an introduction. But it's so much information, it's overwhelming. And I think as a group of people thinking about the right questions to ask and how to kind of get under the skin of something, it's very, very broad. So, I think probably we need to go away as a group of people and think about, are there things that are coming from our communities that we think that we want to do some slightly more, discreet and intense work on. And, I'm not saying today wasn't valuable. It really was very valuable. It's just, I think we need sort of slightly more focused items to come in future. And I think that's down to us to, and maybe recommendations from you guys if you think, actually, it'd be really good if you wanted to explore something specific, because we'd value your questions on it or so on. So, yes, it was just an observation, and I think we need to sort of tighten up maybe for some of our other agenda items in the future.
Thank you, Councillor Harrison. David Watts.
If I could propose a couple of suggestions. So the forward plan from an adult social care is quite light at the moment. predominantly health items in there. We've obviously just recently had the Care Quality Commission in undertaking an assurance process, or as we like to call it, inspection, and the report is anticipated to come out in the autumn of this year. So I'd propose that we would bring that to Health Scrutiny for consideration before we present it formally to our executive. We also introduced last year twice yearly state of our care market reports that go to executive. I'd be suggesting that we bring that at least once to Health Scrutiny, just so you understand how we are judging the quality of our care market, the impact which it has, for example, on our acute providers around discharges. It gives you an opportunity to delve a bit deeper into those. So just a couple of suggestions of other items that could be added to the forward plan, dates to be confirmed.
Yeah, well, thank you, David. We'll take those suggestions away as we look into the plan, okay? Toby, go ahead.
Yeah, thank you, Chair. Just an offer, really, which builds on Councillor Harrison's point, and I was going to sort of hesitating whether to put it in as a suggestion. We're very open to working with you guys in terms of how you shape both the agenda and items that you work through. Scrutiny provides a really important function, and it works really, really well in my experience over lots of years in lots of different counties when you're really well briefed and you've got information you need in front of you. You've got a chance to digest it, and we come along knowing the conversations that you want to have with us and can make sure we feel the right people. So we intentionally today treated this very much as an introductory kind of exercise. I know many of you and you around this committee, around this room. I hope that's been helpful, but we'd be really up for probably following up, Raj, with yourself in terms of how we help to make this as purposeful as it can be, and for you to be able to get the most out of the time that you have with those of us who field into these sessions as well. So thank you for today.
Thank you, Toby. We'll draw this meeting to a close now. It's 9:24, so it's a bit late. Thank you to everybody who's come along today and presented. It's been a very informative initial session, and we look forward to scrutinising your reports going forwards in the future. Thank you.